and thank you all for being here. My name is Casey Minnis. I am the Executive Director of the Multiple Sclerosis Foundation, and I'll be your host and moderator this evening for this program entitled Innovations in MS Care, which we're very proud to have presented by Dr. Barry Singer. Dr. Barry Singer is the Director and founder of the MS Center for Innovations in Care at Missouri Baptist Medical Center. He's an associate professor of clinical neurology at Washington University School of Medicine. And Dr. Singer earned his undergraduate degree from Duke University and his medical degree from Columbia University College of Physicians and Surgeons. He completed neurology residency at New York Hospital, Cornell University, and a neuroimmunology fellowship at the National Institutes of Health. Dr. Singer has been an investigator in more than 35 MS trials focused on new therapeutic options, including remyelination. He serves on the board of directors of the Multiple Sclerosis Association of America since February of 2016 and has a position on its executive committee. His award-winning MS patient education website, www.mslivingwell.org, started in 2008 and has been a valuable resource in over 200 countries. Dr. Singer is also the host of the MS Living Well podcast. We're delighted to have him talking on this important topic. Dr. Singer, I'm happy to turn it over to you.
Well, thank you, Casey. It's great to be with everybody tonight, and thanks for tuning in wherever you are in the world. And I'm happy to start talking about some innovations in MS care because there's a lot going on. I just came back from our global MS meeting, so I'm going to pull slides up. All right. So I want to kind of dive on in and talk about some innovations in MS care. Oops. All right. So the first topic I want to dive into is new insights into the cause and early diagnosis of MS. And so we're trying to get to the root of what actually triggers multiple sclerosis and ways that we can diagnose it earlier, because the sooner we can get it diagnosed, the faster we can get people on treatment. So one of those things that happens early in MS is called the MS prodrome. And so what is the MS prodrome? So prior to having that first attack, whether it be visual loss on one eye or numbness on one side of your body, a lot of people with MS have some symptoms and are going to a doctor for non-neurologic symptoms. For example, rashes, skin conditions, gastrointestinal problems like irritable bowel syndrome, and even psychiatric conditions such as depression or anxiety. So it turns out there's good research that has been done in Canada and British Columbia that looking for the 5 years prior to getting diagnosed with MS, people are going to the doctors more frequently, taking medications for these other conditions, and even hospitalized. There was an interesting study that was just done, that was just presented at our global MS meeting last week in Milan, that actually some people were going to the doctor for 10 to 12 years prior to getting diagnosed with MS were actually missing work, not going to work as much as they normally would, having more days off. And that started 10 to 12 years before they actually developed the first attack of MS and get diagnosed with MS. So we call this the MS prodrome, and there may be ways that we can make a diagnosis sooner in people with these symptoms. So a lot of research going on that front. Another early aspect of MS is something called radiologically isolated syndrome. And so what this means is there's some people that get an MRI scan for an unrelated reason besides a neurologic symptom. For example, They may have get in a car accident, bump their head, and someone does a CAT scan and sees some abnormalities, and they follow up with an MRI, and lo and behold, they have lesions on the brain. Other people might have migraines, bad migraines, which is not a sign of MS. But when they do an MRI, you find incidentally white matter lesions on the brain that are suggestive of MS. And some of these people will end up having spinal cord lesions, positive spinal fluid. And so we think this is probably the first stages of MS without actually having neurologic symptoms. So we're starting to look at this as a first, potentially some people having lesions in the brain before the first one hits a specific area that causes neurologic symptoms. And there was some recent clinical trials that showed benefit of starting patients that we think are high probability of having what we call demyelination, starting treatment early. One was with trial with dimethyl fumarate, one was with teriflunomide, that showed early intervention was beneficial in preventing that first attack of MS. Another advancement that we're seeing is research on the central vein sign. So as you can see in this picture here on this MRI scan, the eyeballs in the lower quadrant here. I don't know if you can see hopefully you can see my arrow, but this is the eyeball in the front of the brain and the back of the brain. And so you see these little white matter lesions here in the brain. And the white matter lesions inside, you see this black hole. And so these black holes are central veins. And so with most of the white matter spots in people with MS, you can see these actual central veins using a special type of MRI protocol. And over half of them have these central veins. And that's because with MS, what happens is inflammation leaks out around the blood vessels in the brain and causes demyelination or loss of myelin around these veins. Other conditions like migraine, which can cause white matter spots, high blood pressure, smoking, they're not associated with these veins. So it's a way of kind of determining if someone has MS versus other conditions. And in my hospital, we actually, at Missouri Baptist in St. Louis, we've actually already have a protocol in place. So I'm starting to try to figure out if people do have MS, if it's confirmed or not. It's an emerging area. Most places are not going to have this routinely available yet, but it's coming. Epstein-barr virus. So many of you probably heard a lot of excitement about Epstein-barr virus in the world of MS. And the reason is there was some research done that was done through Harvard School of Public Health using blood stored on military service people. So men and women that were in the military, they got blood work checked every 2 years and stored. So millions of vials are stored. And you could look at who developed MS over time. And so if you looked at the people that had not been exposed to Epstein-Barr virus and you follow people over time, you do see that you were 32 times more likely to get MS if you got exposed to the Epstein-Barr virus than if you did not. So it seems like Epstein-Barr virus is an important trigger for developing MS. Now, 95% of everybody out there in the US of adults have been exposed to Epstein-Barr virus, but almost 100% of people with MS. So it was only following people over time that we could show that there was an association of getting Epstein-Barr virus and then developing multiple sclerosis. So it seems to be an important trigger. So then the question is, what can we do about it? How could we intervene? And one of the exciting areas is thinking about Epstein-Barr vaccine. So at the National Institutes of Health and also the company Moderna that makes one of the COVID-19 vaccines are working on vaccines that could prevent EBV infection. So if you could prevent this Epstein-Barr virus infection, maybe we could prevent MS. Unfortunately, a lot of people get exposed to Epstein-Barr virus in childhood. And just from that global MS meeting I was at this past week, we do see that kids in some developing countries because hygiene is not as good as in Western countries. They tend to get Epstein-Barr virus infection when they're very young. And then we may see more MS when people get Epstein-Barr virus later in adolescence and young adulthood. So a lot of interesting research, including antiviral research on Epstein-Barr virus, where that may be important and play an important role. One of the things we know is actually we don't see a lot of people with HIV getting MS, even though both conditions are not uncommon. And but people with HIV are on antiviral medications. So there is some interest whether antiviral medications might help. The other very interesting thing is Epstein-Barr virus is this, some people call it the kissing disease. It goes in the saliva and then it gets into the back of the throat, the tonsils, and then it hangs out in our B cells or B immune cells. And so it's hanging out there. Now, whether it's still, we think that Epstein-Barr virus has some similarities. Some of the proteins in Epstein-Barr virus are similar to myelin, the coating of the nerves. And then we call it cross-reactivity. So the immune system responds to the Epstein-Barr virus and then goes and attacks myelin because of similarities there. One of the interesting things is many of our treatments that we have available, about 40% of the people in the United States are now taking medications that knock out B cells. We may be knocking out the cells that contain Epstein-Barr virus. So the Epstein-Barr virus may be hanging out in B cells, and then taking these B cell depleting medications may be knocking out those infected cells. So some interesting observations there, and we're going to learn more over time. One of the other things that is developing in the clinic to improve care is biomarker testing. And so one of the things that we can do is start looking at biomarkers in the blood. And so when you think about biomarkers, you can think about, like a blood test for MS. For example, if someone's a diabetic, you can monitor hemoglobin A1C. So if your hemoglobin A1C is high, it means that your diabetes is not well controlled. If your PSA is high, you could be at risk for prostate cancer. If your cholesterol levels are elevated, then cholesterol is out of whack. So blood tests have been used to monitor other diseases. And now we're getting some blood tests that we can use to monitor multiple sclerosis. In fact, I just had a patient in the clinic today that we ordered a test on to monitor their disease and get some new insights. Some of these biomarkers or blood tests for MS include look at different aspects. So one of them is called the neurofilament light chain. So you can see a picture here of the neuron in blue, and on the neuron you see myelin here. So the coating of the nerves are myelin, and inside is the axon. So the axon kind of comes down here, and then it's coated with myelin. And so if there's injury to the axon, there is release of neurofilament light chain. So this neurofilament is kind of like a structural protein, almost like scaffolding, and within the axon. And so if there's injury to the actual nerve, neurofilament light leaks into the blood and also goes in the spinal fluid. And you can measure that level in the blood, and it lets you know that there's injury going on in the nervous system. Another type of protein that we measure in the blood is called GFAP, or glial fibrillary acidic protein. You can see there. It's in a different cell called astrocytes, and so that can be measured. And we now have some data that GFAP, if the levels are high, increases the risk for disability. Now, I want to move on to managing the key symptoms of multiple sclerosis. So if we're going to innovate in terms of care, we want to be able to manage the symptoms of MS better. Really important. I just had a new patient I saw about an hour ago, having a lot of different neurologic symptoms from MS. And so dealing with depression, cognitive problems, burning pins and needles. And it's important that we manage those key symptoms of multiple sclerosis. So in order to dive into this topic, I'm going to share a video that I helped created for the website mslivingwell.org when I started in 2008. And so this is a brand new video on understanding, taking charge of MS symptoms. So I'm going to go ahead and play that for you.
The more you know about your MS symptoms, the more you can take charge of them. Let's take a closer look at common symptoms and ways you can manage them as you seek to feel and function better. Fatigue. Start with physical activity in the morning and rest or nap midday. Exercise can reduce MS fatigue and address poor sleep issues like restless legs, sleep apnea, or anxiety. You can also incorporate cognitive behavioral therapy, or if needed, medications like modafinil. Abnormal or painful sensations. Burning, tingling, and pins and needle sensations can be eased with off-label use of prescription medications like gabapentin. Muscle spasms and tightness. Stretching is important, especially before bedtime. Muscle relaxants like baclofen or tizanidine can also help, although they may cause drowsiness. Weakness and balance problems. You can build strength and balance with a recumbent bike, swimming, yoga, and Tai Chi. Shaky or double vision. Prism glasses can address double vision. Shaky vision can be improved with medications like gabapentin or memantine. Bladder and bowel problems. For a problematic urgent need to urinate or urinary incontinence, oral medications and bladder Botox injections can keep you dry. For constipation, increasing water intake, probiotics, and certain over-the-counter medications can help. Sexual dysfunction. Women may require more stimulation due to decreased sensitivity. Men should have their testosterone levels checked, try oral medications, and if needed, consider injection treatment. Anxiety and depression. Participating in therapy or joining a support group in person or online can be a helpful step. Seek professional guidance for medications that can be very effective for people with MS. Cognitive challenges. For short-term memory problems and multitasking issues, speech therapy, reducing distractions at work, and lots of organization can help. Most importantly, speak up. Create your individual plan to manage your most significant MS symptoms with your healthcare team. Great symptom management is key to helping you live well with MS.
All right, so hopefully that was helpful. And if you want to see that video again, you can watch it on mslivingwell.org. But we're going to dive into some of those key symptoms that we just heard about. One of them is the most common symptom of MS is called fatigue. And so there are a couple of different types of fatigue with multiple sclerosis. One of them is like you just feel tired, like you didn't get enough sleep. So this could be first thing in the morning. Some people wake up first thing in the morning, ready to get up, take their shower, and they just feel overwhelmingly fatigued and have to go lie down. Another type of fatigue is physical fatigue. So you're just kind of worn out due to muscle weakness. So let's say both of your legs are weak and you just walked a long distance and you need to sit and rest because your legs are worn out. So that's more of a physical fatigue than a typical tiredness and didn't get enough sleep type of fatigue. So why do people with MS get fatigue? Well, one of it is when you have a lesion in your brain. So on this picture, this shows a normal gray matter of the brain. And there are signals, white matter tracks that help connect different areas of the brain so your brain can process information quickly. And if you have a normal intact brain without any lesions or spots, the information flows rapidly. What happens with MS, as you can see on the right, you have this white matter abnormality, the WM abnormality, which is the lesion in the brain. So the gray matter, which is GM, the gray matter, it tries to get around those lesions. It's got to go around in order to activate the same areas of the brain to complete the same task. And what we can see, there's a type of MRI called a functional MRI, and it shows that people with MS actually are stimulating more areas of the brain to do the same task. So instead of being very efficient at doing something, they're to slow down because you have to activate more areas of the brain. So they may be contributing to fatigue because a lot more mental energy is required to do the same task. There's ways around the obstacles, but it does require more energy. In addition, when your immune system is revved up with a disease like multiple sclerosis, your immune cells secrete a chemical called cytokines. And cytokines are a type of protein that's secreted by the immune cells, and usually to stimulate or suppress the immune system. Example would be like, let's say you have a viral infection and your immune system revs up to fight the virus, but you feel like fatigued and worn out. And part of it's not just the virus, it's your immune system reacting to the virus. And so in one study of 35 MS patients in the Netherlands, one of these inflammatory markers, these cytokines called interleukin-6 or IL-6, was associated with severe fatigue. So increased levels of this inflammatory marker was associated with severe fatigue. And then another study of 30 MS patients in Brazil, cytokines IL-6 and one called TNF-alpha were also high in patients with high fatigue. So one of the other reasons for fatigue is we're secreting chemicals in the body that can contribute to fatigue. So how do you reduce fatigue so that you can live well with the disease? So one of them is fixing poor sleep. So it's first place I start because a lot of people with MS are not sleeping well. So one of the things we can do is address insomnia. So you want to avoid caffeine, so because that can lead to trouble sleeping. Learn how to do relaxation techniques before you go to bed. Turn off those screens at night, so that you quiet down. And if need be, there's some medications that can help with that. A lot of people with MS also have sleep apnea, so they have trouble. They snore at night, trouble breathing. This generally happens more when people have kind of thicker necks or higher BMI, but it's sometimes, some people have severe fatigue during the day, and it turns out they're snoring and their breathing gets disrupted at night. And once they go on a CPAP machine, lo and behold, their fatigue goes away. Some people have restless legs, so their legs get jittery, you got to move them around a lot. And some people just get it actually during sleep. We call that periodic limb movements of sleep. And so if we treat that, sometimes fatigue is much better during the day. A lot of people with MS also get cramps, spasms in their legs. So this wakes people up at night. They got to stretch. So stretching before you go to bed helps. And then also muscle relaxants can help reduce the spasms and cramps in the legs. And then finally, we have some people have disrupted sleep because they're going to the bathroom frequently. So with MS, a lot of people get bladder urgency. Some people, I have patients that are peeing literally 5 times at night. And some people fall right back to sleep, but other people are up for an hour after they go to the bathroom. So we really can work on just working on the bladder issues. Once we fix the bladder issues with potentially medication, sleep gets better, less daytime fatigue. So things can snowball. And other ways that you can work on fatigue is energy conservation. So what does this mean? So you do more of your physical activity in the morning, then you rest midday, and then and then maybe do some light activity in the early afternoon. So planning when you're going to do your activity. Some people call it spoon therapy, the spoon theory or spoon therapy is like you basically start out with that you only have a certain amount of spoons a day, and if you use them up early on in the day, you don't have as much later to take care of your to help you get through your day. Regular exercise can definitely help. So getting, you think like, oh, I'm so tired. How can I exercise, doc? But exercise in the morning in particular is very useful. And many clinical trials have shown exercising regularly reduces fatigue with MS. Another important thing that can help is cooling vests. So keeping your body temperature cool when you're overheated, it makes MS fatigue worse. So cooling vests can definitely help, particularly in the summer. And avoiding excessive heat can also help. So you'll be less fatigued if you go out and do those outside activities in the early morning or later afternoon as opposed to the midday. Planning ahead is important. So having the right mobility equipment for the right situation, if you know you're going long distances, maybe using a scooter or a wheelchair to get out there and then be able to do your activities, and you might save some energy. And it's also important for family and friends to understand. I think this is a very frustrating thing for a lot of people with MS, is that some people just don't understand how one day you could have a lot of fatigue and bow out of activities. You just really are not up for it. And I think sometimes friends and families don't totally understand that, especially if you don't have a lot of physical disability. They're like, well, you should be able to do this stuff. But for MS, a lot of times that fatigue is overwhelming. One of the things that's been shown to help fatigue is called cognitive behavioral therapy. And here's a study that was done in 91 MS patients, and they were treated over 16 weeks. And it consisted of 12 individual sessions with a psychologist trained in cognitive behavioral therapy. And the control treatment consisted of 3 consultations with an MS nurse. And severe fatigue was definitely reduced with the cognitive behavioral therapy. And so on the right, you can see all those different types of things that can be done with cognitive behavioral therapy, including formulating goals, regulating sleep-wake patterns, changing beliefs regarding MS, changing beliefs regarding fatigue, reducing the focus on fatigue, regulation of physical and social and mental activity, addressing the role of environment, and handling pain. So working on these modules with physical therapy, with a therapist, cognitive behavioral therapist, can make a big difference. And worst comes to worst, there's medications. So we use frequently modafinil and armodafinil, which are tend to be my go-to drugs, particularly modafinil. I find it tends to be very effective. Mixed results in clinical trials. Some clinical trials have shown benefit, others have not. But in my clinical practice, it seems to be quite effective. Amantadine is an old antiviral medication that's tolerated well, but sometimes works, sometimes doesn't. And then if need be, amphetamines are typically prescribed for people that are refractory to the other 2 types of medications. And that we're talking about things like Adderall or Ritalin. Of note that these medications are off-label use. These are commonly used for MS fatigue, but do not have a specific FDA approval for people with MS fatigue. So another very important thing that we can work on is mental wellness. And what do we mean by that? So we want to keep you mentally sharp and work on our cognitive ability with people living with MS. So cognition in MS is a big issue. So approximately half of people with multiple sclerosis have some cognitive impairment. Generally, what this means is slow processing speed. So information gets processed slower than someone without MS. We see that because of the obstacles that I showed you on the brain due to the lesions. And a lot of people with MS will report short-term memory problems. There's also issues with multitasking, trying to do multiple things at the same time. easy to get distracted, word finding difficulty, which is a huge issue. So a lot of people have trouble finding words. There was recently an interesting, some research done at Mount Sinai in New York. Then they showed, and they did an antonym test where you had to come up with the opposite word, boy, girl, summer, winter. And you had to come up with the opposite words, and the people with MS frequently have word finding difficulty. This can happen early in the disease, but it tends to get more common with patients with progressive disease, where this issue becomes more of an issue, whether it be, for example, secondary progressive MS. So how do we improve cognitive impairment? Or preserve cognitive impairment? I think the most important thing is getting diagnosed soon and starting on very effective MS medication becomes very, very important. And so that is definitely one of the goals to prevent new lesions on the brain. So we do have data that not only the MS affects the white matter of the disease, but also affects the gray matter of the disease. And so the surface of the brain, as well as gray matter that's deep inside the brain. And so effective MS medication may prevent these lesions from forming. We definitely know that exercise can help and help preserve our brain volume. We call it our reserve, our backup brain. So a certain amount of brain is injured by the MS, but then you have normal, healthy brain. So we want to keep that as healthy as possible. Adequate vitamin D over long term has been associated with better cognitive results. Smoking is about the worst thing you can do with MS. Not only does it lead to significant worsening of physical disability, but also cognitive impairment. In fact, I saw today someone that was in an electric wheelchair, weakness in the arms, and really so still smoking. And stopping smoking is really critical to prevent progressive physical and cognitive disability. Good sleep is important. So you can't function if you're not sleeping well. So again, it gets back to that sleep issue. Depression is going to affect your ability to concentrate and focus. Prioritizing tasks is important. You know, if you're trying to multitask too much, it makes them very, very hard. So with MS, if you're focused on one task at a time, completing that task, it'll definitely help in terms of being more efficient. And then reducing stress can clearly help, which is always a challenge out there because there's always things coming at people from whether it be from work, from home life, all kinds of drama all the time, but reducing stress can help. And then speech therapy can really come up with some tools for you to compensate for cognitive impairment. You don't have a repair drug yet to improve cognition, but speech therapy can help you adapt and function better. One of the things that innovations in routine MS care is use of cognitive testing. So one of the things I do in the clinic is I use a processing speed test that's done on an app. And what you basically do is look at these symbols and there's a key, and then you're presented with a series of symbols and you have to find the right number to match up. So like here, the example, the next one should be a number 7 after 1, 3, 5, 8 should be a 7 because it's the same symbol. So you basically look up here and see the key, and then so this is the same picture. So 7 would be there. The next one would be a 2 based on this one. So it's called a processing speed test. It takes 2 minutes and we do it on an iPad. There's also a paper similar test called the processing speed test, or symbol digit modality test is the other name for it. And so this allows us to measure our cognition, and something I can follow over time and compare it to people of the same age, same education background, same sex, and I can see how you do compared to people without MS, and something I can monitor over time. So it's one way to do this very quickly on routine patient appointments. So what about mental health? What can we do to improve mental health? So improving mental health is really critical. So depression and anxiety are very common with multiple sclerosis. And a Canadian study And of 1,922 MS patients, people with MS, 45% of patients developed depression, and 49% of patients had anxiety. Most of the clinical trials show about half of people with MS have depression. And the causes can be actual brain disease. So we see depression in other diseases of the brain, for example, Parkinson's would be an example. There's also immune changes. And so some of the immune cells, like the cytokines, could be contributing to depression. Reaction to the diagnosis, right? So you're cruising on along in life and someone at 38 tells you got MS. Well, there's a reaction of dealing with that and accepting that and going through that process. Reaction to having disability, not being able to do all the activities that you wanted to do, or being able to stay employed if that's, you're doing a profession that you love. And then medication side effects, which tend to be mostly the interferons. So the interferon injections tend to have depression as a potential side effect. And so we definitely have options, including therapy and medications that are very important to treat anxiety and depression. And these medications can be usually very effective for people with MS. Mindfulness. So this is actually one approach to help people with MS. And so this is about being in the moment, where you focus on what's going on now, not worrying about what happened in the past, not worrying about what's going on in the future, but really it's a type of therapy where you focus on the present. And it's been shown to reduce anxiety and depression, reduce stress, and actually improve cognitive processing speed. So there's even mindfulness videos online, some for MS and not even MS, but maybe something to try to kind of improve your mental wellness. The other thing that we're working on is improving mobility with MS. So it's another important symptom of the disease is a mobility impairment, trouble walking. One of the cool devices that's just came out is in the past year is a brace called the neural sleeve. So you can see the device here. And what the neural sleeve does is it has electrodes that can track your own muscles in your legs, affecting your hamstrings, your calves, so your various muscles, and it uses electrodes that actually stimulate your own muscles to contract, which allows people to walk. It lasts about 8 hours and a day, the battery. And so you kind of build your own strength by walking more and stimulating your own muscles. So it's a new cool device, and one that I've had some success with over the past 6 months. I've had a number of patients get it, and they're starting to have some great results. So to improve mobility, one of the most important things is getting a good physical therapist out. And there's some that are MS certified, some are neurology certified. And so getting a good physical therapist can be really great at improving mobility and kind of assessing where you are. There may be times that you need maybe a wheelchair, or trying to make a decision, do you need an electric wheelchair, a manual wheelchair? Or do you just have a mild weakness in one leg and need a foot brace called an AFO to help you ambulate? Really the goal is to targeted exercise for your weakest muscles to try to improve their strength. One of the weak muscles with people with multiple sclerosis is called the anterior tibialis, which allows you to cock your foot upward. And so sometimes working on that can make a difference. And sometimes the hip flexors are often weak with MS. So raising your knee and bending at the hip. Dalfampridine is a medication that sometimes can help walking ability. So in one trial, about 35% of people responded to medication, another trial, 43%. So it can help. Slight risk of seizures. So approximately 4 out of 1,000 people can have a seizure on it. So that's the downside of trying dalfampridine, but for some people, it really helps a lot. Cooling vests, as I mentioned before, it can really improve mobility, particularly on a hot summer day and you got to go and you want to go to your child's baseball game or grandkids baseball game and you want to go outside and walk on an uneven ground. It can be very treacherous sometimes, particularly in the heat, but a cooling vest can make a big difference. So a lot of things that can be done to improve mobility. So it is important to discuss that with your primary, with your neurologist, or the PA or nurse practitioner that you're seeing for your MS care. So I think what I want to leave you with is a lot of progress and a lot of hope. We have new research that's going to allow us to diagnose MS earlier and allow for more accurate diagnosis. Hopefully some research on Epstein-barr virus could potentially even lead to either a cure or prevention of the disease, which could be phenomenal. Improvements in disease monitoring are now available, like using cognitive testing in the clinic, blood tests, biomarkers are starting to be adapted in the clinic so that we can monitor the disease more closely. And if there's a change, we can move on it faster with so many options with over 20 disease modifying therapies. And then I think very, very important to improve your quality of life, to really have great MS care. It's really managing the symptoms that are inhibiting your quality of life. Some of this can be done through medications, devices, but a lot of it can be done with non-medical ways and non-pharmaceutical ways. And so we need to work on new strategies and innovations to improve your ability to live your best life with the least amount of symptoms of the disease. So I'm happy to kind of break it open now for questions and answers. I do want to leave you with, I do have, as Casey mentioned, I have a podcast called MS Living Well. I've been doing this for about 5 years. So I interview MS experts around the globe on various topics, from everywhere from Epstein-barr virus to fatigue to some of the topics that we discussed. My last one was on mobility. So check it out. It's the MS Living Well podcast. And so I interview experts and patient advocates from all over the world.
All right, thank you. And we did put a link to that website, which has information on your podcast, in the chat for anyone who is interested in that. I'll just take a moment to ask all our listeners, if you would like to ask a question of Dr. Singer, please use the Q&A button on your screen, or you can use the raise hand option and we'll bring you on the line to ask your question personally. We have several questions in the queue already, if you're good to go. So to start with, we have a question from Margie. She said, cognitive behavioral therapy helps with fatigue, correct? Who does cognitive behavioral therapy? Specifically, she's asking about the St. Louis area, but if you could kind of give some advice on how people can find a cognitive behavioral therapist.
Yeah, so probably the best way is usually some departments of larger medical centers should have a therapist that are available for that. It is a specialized program, so you want to get, and so there'll probably be someone that's MS certified can help you with that. But usually through the therapy departments, through larger medical centers should have someone that can do that.
Okay. Our next question is from Facebook. Jess asks, what diet do you recommend? Is there a specific diet?
So it's an excellent question. So there's different diets that have been advocated for the world of MS. The problem is it's very hard to do a great clinical trial because most people know what they're sticking in their mouth. so it's hard to blind it. To do a real proper trial, I think people would be drinking liquid shakes while holding their nose, so they can't smell it or taste what they're taking. So, but there's growing data on a Mediterranean diet being associated with less physical disability. So there was recent data, actually, I just came back from this global MS meeting in Scandinavia that's showing better Mediterranean diet was associated with better outcomes. And a lot of CAT scans at Mount Sinai did a big study looking at diet, and Mediterranean diet was associated with less disability. Someone asked her at a American Academy of Neurology what was the driver behind the Mediterranean diet, and she said olive oil. So olive oil may be quite useful. Other diets have been studied in intermittent fasting. So that can be, there's some data in MS as well as in other autoimmune diseases that intermittent fasting can help, but it's hard to maintain that long term. And I've seen people get a little too crazy with that. In fact, I had someone that had wasn't feeling good because doing that and then working out very hard. I mean, so you kind of have to watch it. And if you got diabetes, it could be an issue. So I think it's really important to talk to your provider before doing a diet like that. There have been, data out there for modified paleo diet, which is part of the Walls protocol. There was an old diet, swank diet, which was a low saturated fat diet. We think saturated fat may drive inflammation. For example, people that have high cholesterol levels seem to have higher risk of relapses. So we think sometimes that pro-inflammatory high-fat diet may be pro-inflammatory. Yeah, there's some trials going on, but unfortunately, it's, again, hard to blind those, so we know for sure.
Okay, thank you. And our next question is from Elizabeth. She says, modifenil worsened my sleep due to long duration. Would a short-acting Ritalin be effective for fatigue?
Yeah, so that's a good question. So yeah, some people take modafinil even a low dose. I mean, usually it's 100 to 400 milligrams. And some people, even a low dose, just keeps them wired and they can't sleep. So sometimes, yeah, low dose of Ritalin, methylphenidate, can do the trick. So that would be an option. I also find that amantadine is a little more gentle and not as potent. So a lot of my patients that can't handle modafinil, sometimes we try the amantadine, which is cheap generic, it's been around a long time. So that may be an option.
Our next question is from Ree, who asks, do you need a prescription for the neural sleeve, and is it covered by insurance?
So neural sleeve is not covered by insurance at this point. But you don't need a prescription initially. First, we generally reach out to the company and then they fax me a form to sign off on. Basically what they charge for, you try it per month. So they charge $200 a month for the first year and then you own it. So it's about $2,400 total investment. But if it doesn't work out and you try it for a month or two and you don't like it, you can send it back and not obligated to pay anymore. So frankly, it's it is an expenditure, but if it makes a significant difference in walking, it's most of my patients find that it's doable if it allows you to walk much better. So, but it is it's not covered by insurance yet. Hopefully that'll change.
Hopefully. Rebecca from Facebook asks, have you heard about the possibility of an inverse vaccine for MS?
Yeah, so there's some interesting research being done, including one of the companies that has a COVID-19 vaccine is using mRNA vaccines as potential for treatment. Kind of early stages, still some animal model stuff, data going on. So I think we got there was some buzz just recently in the press about it, but I think it's got a little ways to go, but some interesting ideas about using vaccine for the treatment of MS. I've been involved in some of that. An early trial, we were using something called altered peptide ligand to kind of trick MS and decrease immune inflammation. So there's been some research on that front. We got a little ways to go.
We have an anonymous attendee who asked, Is it true that people with MS have difficulty with not being able to sweat?
No, not necessarily. In fact, I've had some people say the opposite. They sweat too much with MS. But sometimes the medications do that. So one of the side effects of particularly the bladder meds block a chemical called acetylcholine. And if that happens, it can make you dry. So some of our bladder meds, for example, one called oxybutynin, which is a bladder medication that prevents bladder urgency, can dry you out. So you may want to look at those medications because sometimes that's a common side effect of some of those meds.
All right. Meta asks, what supplements should people with MS consume other than vitamin D to treat MS in general and blurred vision in particular?
Yeah, so we don't have a lot of great data on supplements. So vitamin D, we have pretty convincing data that low vitamin D has been associated with more MRI activity, more relapses, and higher levels of disability. One of the best studies was over 5 years and looking at people where, well, it's actually even longer than 5 years, but we looked at people with the lowest vitamin D versus the group with the highest vitamin D, and you could kind of plot it out. We don't have that strong data with other supplements. So I have many patients that take all kinds of various supplements. So I think it's important when you go into your neurologist or whoever you're seeing for your neurology care, is to really look at the supplements and discuss which ones you're taking. Sometimes they may interact with something else you're taking. So you just want to make sure you're on the same page. Specifically, biotin, that's a lot of people take for not necessarily MS, but they take it for hair and nails, can affect blood tests, including thyroid blood tests. So it is important that we keep that in mind. Unfortunately, it's very hard to show that supplements make a big difference. There was a big study again with biotin, but it didn't pan out.
Where our time left is limited, so I encourage folks to get their questions in now. I am going to skip around a little bit in some of the questions. The next one is from Douglas, who says, for those unable to lie still for an MRI, is there an alternative method of testing for lesions or lesion enhancement?
So that's an excellent question. So there is a blood test that can be done. I've mentioned biomarkers. And so there is a biomarker panel that's associated with the disease activity. The company is Octave, and they do check 18 different proteins. And having a high disease activity score, it's on 1 to 10. So if you're like a 8, 9, or 10, then you have a high risk for developing new activity on the brain. And so that could be quite useful in terms of reducing, it kind of predicts that you have high risk for new activity. A lot of people, though, are claustrophobic. So, sometimes we have to find an open MRI or use some medication. I frequently use diazepam to reduce the risk of if people are claustrophobic or have trouble lying still, sometimes some little diazepam can make a huge difference, which is another name is Valium. So we do use that sometimes for patients. But we can kind of figure out some options. So usually we can figure out the MRI. Occasionally general anesthesia, but not very often. You got to be really claustrophobic for that.
An anonymous attendee who is a 20-year-old male college student said that he was told he has one lesion area with demyelination showing on MRI, bilateral hand tremors, no other symptoms, and he was told that he has CIS. He's asking, what would your recommendations be?
Well, generally, if you have only one lesion and you don't have, if you have more than one attack, you could have a diagnosis of MS that's been proven. But if you have only one lesion and only one attack, then generally patients are fouled. So we want to make sure that generally to diagnose MS, we're looking for events that happen over time. So we call it dissemination in time. And then we also want to see dissemination in space. So that means you have maybe like one lesion in the surface around the fluid-filled spaces of the brain, one lesion in the spinal cord, or one lesion in the brainstem. So we're looking for different areas. So it's not just a one lesion disease. And then we're also looking for dissemination over time. One way that we can make that diagnosis when someone is newly diagnosed with MS, we look at, are there any active lesions and old lesions at the same time? And that would give us a sense that it's happened over time. Positive spinal fluid with bands in the spinal fluid is a sign that there's inflammation over time. So we have criteria, it's called the McDonald criteria, that and that gets updated on a regular basis. So the McDonald criteria can help determine if someone is strong enough evidence to support a diagnosis of MS. If it doesn't meet criteria and you only have a solitary lesion, some people we file over time. Some people will go on to develop definite MS and some people not. But usually with one lesion and only one attack, we wouldn't start disease modifying therapy. But again, that's something to discuss directly with your own healthcare provider to make sure you're on the right track and be monitored closely.
Good advice. Another anonymous attendee said, you talked about DMTs that are highly effective. Are they highly effective for primary progressive MS? Most of what I have heard is that DMTs work most effectively for RRMS, and that at this time there's only one for PPMS. Any hope for PPMS?
Yeah, there's definitely hope for PPMS, but that is correct. There are only one is Ocrevus or ocrelizumab is the only FDA-approved treatment for primary progressive MS. And primary progressive MS is about 10 to 15% of people who, when they start with MS, it's just slowly getting worse over time. So their legs are slowly getting weaker, their balance is slowly worsening. And from the very beginning. So there was no relapse at the beginning, like loss of vision for 2 weeks out of one eye or double vision for a month, or numbness in the legs, it got better. So there's no relapse at the beginning, so it's primary progressive. There are clinical trials now going on for primary progressive MS. And so a couple of those are in a class called BTK inhibitors, and we should be seeing those results are ongoing clinical trials for that. And there's other agents that are also being looked at. So I think it's, if you're interested in clinical trials and looking for other options, one great website to go is clinicaltrials.gov. So it's a US government website, clinicaltrials.gov, and you can put in primary progressive MS and see about all the trials that are recruiting. And you can also see where their sites are located to see if there's sites near you.
We have time for just one more question. So I'm going to speak directly to a couple of our questioners here really quickly. I know, Tina, you were hoping for more information on DMTs and remyelination. If you reply to your registration email, we'll go ahead and send you information on where to find out more about the various DMTs. So Dr. Singer, if you would, we had a question from Nadja who says that she is suffering from chronic pain that gives her serious problems with sleeping and spasms. And she's wondering if you could talk a little bit more about how to manage chronic pain.
Yeah, so I think one of the things that can be done for spasms, there's a lot of different options, and that's a big issue for a lot of my patients. So what we tend to do for people that are having a lot of spasms is try to start generally with muscle relaxants at night. So they tend to be the best approach. And there's things like baclofen, tizanidine, diazepam that we tend to use first line to help with spasms at night. If there's severe, like sudden jerks of the legs where the legs spasm out severely, Sometimes there's medications like oxcarbazepine or gabapentin that can help. So we call those extensor spasms, and they can be very painful. Other options include medications such as Botox injections in the legs. And even for some people, pump can be put in to drip spinal fluid, baclofen right into the spinal fluid. So if it's severe spasms, sometimes a baclofen pump can be an option. And so those are very good options. And then in terms of pain, we have medications for burning, pins and needles, tingling. And so those can make, so nerve pain, there's definitely some options there as well. I showed some of those in the video. So actually, if you go to there's a section of managing MS symptoms and MS living well. I have some of those, all those different options for nerve pain as well. But they can make a big difference. Just in terms of that one question on remyelination, which is repairing the damage that's happened in myelin, it is a very important topic. I've done 5 clinical trials on myelin repair, but I haven't hit yet. So I haven't found one that works really well yet. But there is a lot of interest in the field and coming up with a molecule. Some of the treatments that I've studied have been antibodies, and it's hard to get an antibody into the brain to repair damage. But we do know that somewhere between 5 and 8% of the cells in the brain have the ability to make new myelin and to repair the damage that's happened. But we don't have anything quite just yet.
Okay, thank you so much for that. We are at our time, so for anyone who did not have an opportunity to get an answer to their question, please feel free to reply to your email, and the foundation will try and get an answer to those questions to you. Dr. Singer, thank you for taking so many questions and so efficiently. You just kind of whipped right through them. We really appreciate that. It's great when we can get to as many people as possible. So folks, that brings us to the end of our presentation tonight. If you missed any part of this conference, it has been recorded, and in just a few minutes, it will be available under the videos section of the Multiple Sclerosis Foundation Facebook page. And a little bit later, it will become available on our YouTube channel, so you can go back and watch it at any time. If you need links to get directly to that information, again, go ahead and reply to your registration email, and we'll be able to help you get that information or get signed up for our newsletter to learn about upcoming events. Our next program is going to be next Wednesday on 10/25 at 5 p.m. With Dr. Drew Leader talking about how to heal when there is no cure. We thank all of you for being here tonight, for your attention, your questions, your active participation, and especially our thanks to you, Dr. Barry Singer. Thank you so much for your time putting together this information, sharing your expertise, and answering our questions. We really appreciate you.
Okay, well, thanks, Casey, for the invitation, and my best to everybody out there living with MS. It's important to get the care that you really deserve. So it is important to be an advocate and speak up, like I showed you in the video.
Absolutely. Thank you so much.